discuss about the gestational trophoblastic diseases. So this is the normal placenta. So the umbilical cord is inserted into the fetal surface of the placenta. What we look is the fetal surface. Note the vessels radiating out from the cord over the fetal surface in this normal term placenta. Okay. So this is the other side, the maternal surface of a normal term placenta is seen here. Note that cotyledons that form the placenta are reddish brown and indistinct. So these are called as cotyledons, which are seen on the maternal surface of the placenta, where this part is attached to the uterus. Okay. This is the normal villi of the placenta of 7 to 8 weeks of pregnancy. So there are several immature villi. So this is the early pregnancy. So these are all immature villi. So these villi are separated by the intervillous space, that is called as IVS. So these villi exhibit a thick double layer of trophoblast. So normally the villi are lined by double layer. Inside it is a single layer of cytotrophoblast, and the outer layer consists of syncytial trophoblastic cells, so which are having the syncytial cytoplasm, and multinucleated presentation will be seen. And these contains the scattered blood vessels and abundant loose stroma will be there. So here you can clearly appreciate the two layers of the cytotrophoblast, the inner side, and the outer surface, that is towards the intervillous space there is a syncytial trophoblast. So the stroma contains the vasculature, the vessels. Here you can see these are completely filled with that of the nucleated RBCs. Okay, so we can appreciate the nucleated RBCs of the fetus. So this intervillous space, here the maternal blood will flow. Okay, within the villi, the vessels, they are called as the fetal blood vessels. There the fetus blood will flow in those capillaries. So here you can still appreciate the black arrow showing the vessels containing nucleated RBCs. So, and the green arrow showing the cytotrophoblast, and the blue arrow showing the syncytial trophoblast, which is the outer layer. So this is the first trimester placenta. The chorionic villi of the placenta are large, covered by the two layers of cells, that is cytotrophoblast and syncytial trophoblast. The blood vessels in the villi are not prominent in this. So here you can appreciate some cells are being proliferated and forming the clusters of cells. So these are called as intermediate trophoblasts. So what happens actually is the placenta after implantation enter into the myometrium, that is endometrium and myometrium. This endometrium to establish the maternal and fetal circulation that will support the growing fetus. Seen here are the clusters of intermediate trophoblastic cells on the first trimester villi that help to perform this function of establishing the placenta as it invades. So it invades, already the placental bed will be formed by the endometrium. Into that endometrium, these villi will enter and invade. So for that invasion, these intermediate trophoblastic cells will help in the establishment of this maternofetal connection. So coming to the diseases proper. So what is GTD? That is gestational trophoblastic diseases. So these encompasses a spectrum of tumors and tumor-like conditions characterized by proliferation of placental tissue, either villous or trophoblastic. Either there is villous proliferation or the cells, the trophoblastic cells is proliferated. So there are grossly we can divide them into 4 types: hydatidiform mole, invasive mole, choriocarcinoma, and placental side trophoblastic tumor. So hydatidiform mole can be 2 types, that is complete and partial based upon the morphology and cytogenetics. Invasive mole, So mole, if it invade, it is called as invasive mole. Choriocarcinoma is a malignant one, and placental site trophoblastic tumor is a tumor-like condition. So coming to the herediform mole, so otherwise called as molar pregnancy. In Telugu, it is called as Mutyala Garbham. So it is filled with like pearl-like pearl-sized vesicles will be filling the endometrial cavity, that is the uterus. Okay, so that's why it is called as Mutyala Garbham in Telugu. Okay, so this herediform mole, these are important to recognize because these are associated with increased risk of persistent trophoblastic disease, that is invasive mole or choriocarcinoma. So moles are characterized histologically by the cystic swelling of the chorionic villi accompanied by variable trophoblastic proliferation. So basically you need to remember these villi are cystically dilated. So that's what I told you, they are grape-like vesicles will be there. So these vesicles are nothing but they will contain the fluid. So they are nothing but the dilated villi. Okay, that you need to remember. And second thing is there will be trophoblastic proliferation. Okay, these two are basic requirements to call it as herediform mole. So they are usually diagnosed during early pregnancy. Average gestation will be 9 weeks by the pelvic sonogram. So they can be diagnosed by the ultrasonography. Ultrasound is the investigation of choice and it can be confirmed in the test. So the molar pregnancy can develop at any age, but the risk is higher at the two ends of the reproductive life, that is early, that is teenagers, or 40 to 50 years, that is the upper limit. So for poorly explained reasons, the incidence varies considerably in different parts of the world. So two types of benign non-invasive moles are identified by the cytogenetic and histological studies. They are complete and partial moles. So complete mole. So complete mole, what is the pathogenesis of complete mole? So whenever an empty ovum is fertilized by a single sperm with a haploid type of chromosomes, that is 23X or 23Y, or an empty ovum is fertilized by two sperms, two haploid sperms, that is called as dispermy, it can give rise to a complete mole. So here the cytogenetic analysis will show us this is a duplication of chromosome will happen, so it is a diploid. So it is a diploid chromosomal number will be there, that is 46XX, that is homozygous if it is fertilized by a single ovum, or if it is fertilized by two different sperms, then it is called as heterozygous complete mole. So it is homozygous when it is empty ovum is fertilized by the single sperm, and it will be heterozygous complete mole when it is fertilized by the two sperms. Okay, that is important. So this is a gross picture. So you can appreciate in the first image, you can appreciate it is a cut opened uterus with on either side you can see the bilateral adnexae, that is ovary and tube. Okay, this is a cut open, it is filled with the vesicles. So in the lower image it is showing the closer view, showing the pearl like vesicles. You can appreciate multiple varying sized vesicles or grape like vesicles are seen. So this is forming the complete mole. Also coming to the microscopy, I have already told you the basic requirement to call it as a herediform mole is there should be dilated villi and there should be trophoblastic cell proliferation. So this is what you are able to appreciate. These are dilated, enlarged, edematous villi, and these villi are avascular. There is no vasculature. Avascular villi are hydropic villi. And second thing is there will be cistern formation within the villi. And the third one is there is increase in the cyto and syncytial trophoblastic cells. So here the important point to differentiate complete from partial is in complete there is diffuse proliferation of this trophoblastic cell proliferation. Okay, so in the case of partial mole, only partially, only focally there is proliferation of the sensation cytotrophoblast. So hydropic villi, trophoblastic hyperplasia, and cistern formation, avascular villi. These are the four important microscopic features you need to write for a mole, complete mole. So here is a, you can appreciate this here very well. These are the dilated villi, and you can see the hyperplasia of the trophoblastic tissue, that is cytotrophoblast and syncytial trophoblast, and you can even you can appreciate the cistern formations also. There are space formation, cavity formation within the villi, and there is no vasculature. So here again in the A, low power is showing they are all enlarged, dilated, edematous villi, hydropic degeneration of the villi are seen. In the photo B, you can appreciate there is hyperplastic trophoblast. Trophoblastic hyperplasia is present. It is very much evident. Coming to the partial mole. These partial moles results from the fertilization of an egg with two sperms. So here the egg will have the genetic material. It is not a blighted ovum. It will have the genetic material. So because of that, these moles, the karyotype is usually triploid. So triploid, that is 69XXY, or occasionally tetraploid, 92 XXY. So fetal tissues are typically present. That's why it is called as partial mole. Only a part of the placental tissue is being converted or transformed into the hydropic degeneration, but the rest of it will be normal, will be present, along with the fetal parts will also be appreciable. So these partial moles will have increased risk of persistent molar disease, but are not associated with choriocarcinoma. So this is what the ovum will have, the 23 eggs, and it is fertilized by the two sperms, that is dispermy. Then it can give rise to a triploid partial mole. So this is a partial molar pregnancy. Some of the vesicles are, you can appreciate, this is the placenta, this is the card, and this is the fetus. So in the placenta, if you can clearly appreciate, there are some of these are showing the this grape-like vesicle formation. So this is the partial hydatiform mole microscopy. The trophoblastic proliferation is slight and it is focal, and there is edematous as usual, and there are avascular villi. And second thing is scalloping of the villi occurs. Because of this, these are called as inclusions. Trophoblastic inclusions can be seen within the partial mole. Okay, this is nothing but these epithelium, that is lining cells, trophoblastic cells will try to invade as into the stroma, and they appear as invaded, and they form the inclusions. So these inclusions can be seen in the case of partial hydatiform mole. So this is again the same, you can appreciate the same here. There is they are very much large villi with inclusions. Trophoblastic inclusions are there. Avascular villi are appreciable here. So coming to the clinical features. So most women with partial and early complete moles present with spontaneous miscarriages. So that is one of the reasons, or they undergo curettage because of ultrasound findings are abnormal. Villus enlargement is seen in the findings. So in complete moles, the HCG levels greatly exceed those of a normal pregnancy of a similar gestational age. For example, in 9 to 12 weeks of pregnancy, the normal levels of HCG are 25,700 to 2,88,000. Okay, so there is a very much varied range is there. So milli international units per ml. So here the normal value at the level of 9 weeks of gestation, these levels are very high. They exceed even the normal levels. So in addition, the rate at which HCG levels rise over a time in molar pregnancies exceed those seen in the normal single or even multiple pregnancies. And second thing is the uterine size will be more than that of the size of for a normal gestation, large for gestation. Okay, so coming to the treatment, so most moles are successfully removed by the curettage. So the patients are subsequently monitored for 6 months to 1 year to ensure that HCG levels decrease to non-pregnant levels. So continuous elevation of HCG may be indicative of persistent or invasive mole, which develops in up to 15% of the molar pregnancies and is seen more frequently with the complete moles. So complete mole can most of it can convert into invasive mole, okay, in 15% of the cases. In addition, 2.5% of the complete moles give rise to gestational choriocarcinoma. That we need to remember. Coming to the invasive hydatidiform mole. So it is nothing but I have already told you. Usually this I told you that the curettage is a treatment. Here it has invaded even into the myometrium also. Okay, so that's what this is, a hydatidiform mole in which hydropic villi invade the myometrium or blood vessels, or more rarely are deported to extrauterine sites. Although invasive hydatidiform mole is not a true neoplastic disease, it is often considered to be clinically malignant, since the lesion can invade the myometrium and can metastasize. Invasive hydatidiform mole is a possible sequela of a hydatidiform mole, which is virtually always a complete mole. The pathological diagnosis requires demonstration of the molar villi invading the myometrium or deported in the extrauterine sites. So here is a gross image. So the uterus, this is a cut section of the uterus. You can see already all erosive hemorrhagic lesion extending into the myometrium wall with the perforation and involvement of the broad ligament, which is not seen here, but it is clearly appreciable that there is a invasiveness and destruction of this myometrium is also appreciable. Here the molar vesicles in invasive molar pregnancy. See, this uterine myometrium is being thinned out and is almost appears to be seen outside. So coming to the microscopy, the diagnostic feature is the presence of molar villi along with trophoblast in the myometrium or at an extrauterine site. The trophoblastic proliferation with atypia accompanies the enlarged villi and is as variable as in a non-invasive hydatidiform mole. Okay, whether it is invasive or non-invasive, atypia can be seen, ranging from the slightly proliferative with minimal atypia to marked trophoblastic proliferation with extreme atypia is possible in the invasive molar pregnancy. So here it is a microscopy of the invasive mole. You can appreciate this is the myometrium, which is I have already labeled. So these are the villi, and here you can see the trophoblastic hyperplasia. The villi are dilated and there is hydropic degeneration. So these villi are seen entering or invading into the myometrium. So here you can see the exuberant trophoblastic proliferation. Here the arrow is showing the proliferated cytotrophoblasts. So with this we have covered a part of the gestational trophoblastic diseases.